So we know that from the genetic studies and of PCSK9 gene variants and loss of function, that glucose levels are a little bit higher. Now, it's actually not the whole population; it's the people with pre-diabetes, if you will. So the theoretical concern would be that in a population with diabetes, does glycemic control deteriorate? Now, usually you would see that by a change in background therapy, i.e. you've got to intensify treatment. So that's one of the theoretical concerns one might have. But in terms of efficacy, we have no concerns, and in theory, diabetics should benefit more from PCSK9 inhibition than non-diabetics. So far in the phase 3 program, in the Odyssey trials, we've had a subpopulation with diabetes, so 30% of the 4,800 had diabetes, but we've not specifically looked at patients with diabetes per se. And there are two groups of special interest. Those on insulin, so type 1 and type 2 patients. So Odyssey Diabetes Insulin really tests that patient population and looks at people on background therapy with statins, comparing Alirocumab against placebo. The usual design, 24 weeks, primary endpoint LDL reduction at 24 weeks compared to placebo, but everybody is on insulin, both type 1 and type 2 patients, and we're presenting the type 1 patients for the first time here. And the second group is the population with diabetes dyslipidemia. So we know people with diabetes, their LDLs are often very similar to non-diabetics, but they have high levels of TG, and they have low levels of HDL, so they have higher risk as a result. And what we don't know is actually, what to do in that situation. One option might be a PCSK9 inhibitor, but usual care currently is a whole host of options: fenofibrate, maybe ezetimibe, maybe fish oils, maybe niacin, maybe nothing, because the evidence base for some of those is relatively weak. So in the Odyssey Diabetes Dyslipidemia study, we're looking at non-HDL, which is a better predictor of risk and benefit in people with diabetes for the first time. 24 weeks again, but we have basically stratified the data, so investigators choose what they would normally do. Would I give fenofibrate? Would I give niacin? Would I give ezetimibe? And then randomize them to either Alirocumab or usual care. So we're going to present that data for the first time, particularly the data against fenofibrate. Well, very consistent with what we've seen in the overall patient population, that we saw that Alirocumab significantly reduced LDL cholesterol by about close to 50% compared to placebo in the insulin studies. Glucose control, which is the major safety endpoint, HbA1c, add-on therapies, didn't change, so you maintain glycemic control, and that was one of the theoretical concerns that people may have had. In the dyslipidemia study, because we're looking at non-HDL as a measure of outcome, you saw almost a 40% reduction in non-HDL cholesterol compared to usual care, better than fenofibrate. Fenofibrate really doesn't shift non-HDL, and essentially superior to all the other control groups. Again, no impact on glycemic control, need for background therapy being increased, etc. So we've shown efficacy and safety. No, absolutely. But remember, with the statin trials, it took many, many years and large number of patients, because these are rare events. These are not common events. So we do need longer term follow-up. But what it does tell us is, should we be concerned right now? And the answer is no. If data emerges in the future that says otherwise, then okay, maybe monitor people with annual HbA1c changes, particularly if they're pre-diabetic, they've got metabolic syndrome, etc. But currently, the data that's been presented with Fourier at this meeting shows that people with diabetes benefit to a similar extent as those without, and there is no effect on glucose control. No, I don't think you need outcomes trials in specific diabetes populations, because diabetics have a high risk. And so, for example, in Odyssey Outcomes next year with 18,000 people, over a third have diabetes. And you might actually see a significant benefit simply based on the fact that they have such a high risk, even though 1/3 of the patients, 6,000, have diabetes. We'll have a large number there. And the same was observed in Fourier. Out of the 27,000 individuals, about 1/3 had diabetes, so they saw a significant benefit in that patient group. So there's no need to do a separate study in people with diabetes. But we've got to remember, all of these people are individuals with diabetes and ASCVD. So we haven't seen data yet in a diabetes primary prevention population. And pure primary prevention with no other risk factors is actually a low-risk group. So you're going to have to enrich for people with microvascular disease, long-standing diabetes, and that would be, a future study in primary prevention. But we'll have the data for diabetes with ASCVD with 2 studies in the next year.